Welcome to the third day of North Idaho College's Popcorn Forum Symposium on Universal Health Coverage in the United States, Can We Do It? I am particularly pleased to welcome you, Dr. Maiuro, to North Idaho College and to our symposium. Our speaker this morning is Dr. Roland Maiuro, Director of the Harborview Anger Management and Domestic Violence Program and Associate Director of the Behavioral Medicine Clinic, both at Harborview Medical Center in Seattle. He's also an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine, so he's both a practitioner and a teacher. He received his Bachelor of Arts degree in Psychology and Biology from Rutgers University, headed west, got his PhD in Clinical Psychology from Washington University in St. Louis, Missouri, continuing his movement west, did postdoctoral studies at the University of Washington School of Medicine. In addition to his academic credentials, he is also a licensed clinical psychologist in the state of Washington. He has gained international recognition as an expert on the assessment and treatment of anger problems and violent behavior, stress and coping, and community mental health. His work in these subject areas has included teaching, conducting numerous research projects, and doing extensive writing. He is currently editing a book called The Handbook of Family Violence for Healthcare Professionals, as well as serving as the chief editor for the Journal of Violence and Victims, a multidisciplinary journal devoted to theory, research, and practice in the field of violence and victimization. In addition, he's been a consultant to a variety of agencies and organizations regarding public health aspects of domestic violence, including the House Health Subcommittee of the Washington State Legislature and the National Institute of Mental Health. His work has earned him numerous awards from state and national professional organizations, and next month he will be one of only 2 United States representatives to the International Conference on Violence to be held in Rome, Italy. It is my privilege to introduce to you Dr. Roland Maiuro, who will speak on the impact of violence on healthcare in America.
I'd like to start by thanking Margaret for that very nice introduction, and also Tony Stewart for the invitation to join you for your 24th Popcorn Forum. As you know, the topic relates to violence and its impact upon healthcare. After hearing those credentials and the type of work that I've done, often people in the audience wonder just what type of guy it is that devotes his career to this type of area. They often wonder whether they should interrupt me while I'm speaking and ask questions, how I might react. I want to assure you that I will not become angry or violent should you do that. I want to encourage you, in fact, to ask questions as we go along. Some of the material I'll be presenting is rather sobering. Some of the statements that I make hopefully will be controversial and thought-provoking. But I want to encourage you that should you interrupt me at any point, I will not become angry or be prone to violence. I have an affirmation, a self-statement that I make to myself every day. In fact, I say, you know, Roland, whatever happens, no matter who interrupts you, no matter how much your train of thought gets derailed, you cannot become angry and certainly not become violent. After all, you work for the state of Washington. So that helps me every day keep my sanity myself. I wanted to begin by telling you that there'll be 2 major thrusts to my focus here on violence. There are many, many different types of violence that go on in the United States. There are 2 types that are of great interest to the healthcare system currently. One is known as family violence or domestic violence, much of that being violence towards intimate partners, in many cases women and children. Another type of violence is youth violence. And of course, you're probably well aware of the news stories relating to this. and there are essentially waves, epidemic form of youth violence in this country, which are projected, by the way, to continue for some years to come. Both of these forms of violence are very worrisome. They are interconnected, and they do have a major impact currently on our healthcare system. And I'm going to be focusing a lot of my discussion and presentation on those two types of violence as they relate to the healthcare system and to the community in general. I'd like to begin the discussion by having Lindy put on a videotape. This is a news story that we recorded just about a year and a half ago in Seattle, and it describes a particular pattern of violence. It's my understanding that you've had a number of episodes of this type of violence recently in this area.
The defense in the Randy Roth murder trial began in...
Good evening. More than a year before it happened, a Tacoma mother predicted her two sons would be murdered by their own father.
Today, 37-year-old Cherno Kamara is charged with 2 counts of aggravated murder, as well as the attempted murder of his ex-wife. The attack happened in this home in Tacoma on Friday night. Police say Kamara killed his 2- and 3-year-old sons with a hatchet. Como News 4 has obtained court documents that show his ex-wife, Patricia Johnston, filed for court protection a year ago. She wrote about Kamara, he threatened the life of our oldest son, and over the last several months reiterated that the children are his possession, and he has the right to kill them and himself. Kamara is from the Gambia in West Africa. Johnston said if he realizes he can't take the boys to Gambia, he may feel he has no choice but to kill them. I believe there is mental illness involved, she said. He is unpredictable. Kamara pleaded not guilty this afternoon. He remains jailed without bail tonight. Prosecutors say they may ask for the death penalty. Also in Pierce County, a man accused of shooting his wife to death in this car faces first-degree murder charges once he recovers from what police say are self-inflicted gunshot wounds. The shootings happened Saturday night following what neighbors say was an argument between the couple outside their home in Parkland. The man remains in critical condition.
This weekend's tragedies point out one hard fact. Our families are becoming increasingly violent. Como's John Larson talked with the people who are trying to find out why.
Stand outside the doorway of Harborview Hospital's emergency room. You'll see a side of the American family here you won't like very much. 1 of every 3 women rushed here with traumatic injury, gunshot wounds, knife cuts, broken bones, has been attacked by her husband, boyfriend, the man in her family. Beverly showed up at Harborview after a fight with her husband with a broken bone, bruises from head to foot.
He tore up the room, broke pictures off the walls, broke tables, had a table leg, threatened me with hitting it over my head, tied me up. I mean, it was like the worst.
Domestic assault.
Despite tougher laws, better training, new shelters for victims, domestic violence is growing in every socioeconomic group. Beverly eventually got out and got help, but most victims never do. In this weekend's shooting death in Parkland and the axe murders in Tacoma, both families had histories of domestic violence. Both husbands had been ordered by the court to stay away from their wives. It didn't work.
For some people, nothing is going to help. No restraining order, no counseling, anything that you can think of. There are some individuals who will simply get to their target and will kill their target.
We've made some progress with victim support services. With passing tougher laws, enforcing them, but much of this is after the fact. It doesn't work earlier on where we really need a lot of help to break the cycle of violence, to stop it. Thank you. The pattern of violence there, I remember someone asking me at the time, boy, what do you think of this episode of violence where this man killed his children? And attempted to kill himself. Boy, isn't that strange, the type of beliefs they have in Gambia. And my response to them was, well, you know, it's not strange at all. Those types of beliefs, that pattern of violence, is not at all characteristic or any more characteristic of Gambia than it is of the United States. This is an article that was published, a research article in the journal Violence and Victims, which I edit. In fact, that demonstrated that this pattern is one that is very, very common to the United States. This was a cross-cultural study that attempted to examine what had been clinical thinking, that there's increased risk to women, intimate partners, at times in which they break relationships with men, whether it be boyfriends or spouses. In fact, the researchers found that this pattern could be replicated not only in the United States, but also in Canada and in Australia. So this is a time of great risk to women, and there's a complex pattern of dynamics that develops that makes it a very, very high time of danger, particularly if there had been a history of violence or abuse in the relationship. You know, one of the reasons, and you heard the statistics there in terms of violence and what impact it's having in our healthcare system. And if there is a protocol in an emergency room setting in an urban hospital, those sort of statistics will be found. Many injuries come in, and heretofore there weren't protocols to determine the source of injury. In many cases, victims had been bandaged, stitched up, and sent on their way. And it wasn't recorded as to what the source was. The estimates are that 25 to 30%, if you put a protocol in place for asking the right questions supportively and with confidentiality, you will find, in fact, that violence is the leading cause of injury to women seen in emergency rooms in urban hospitals across the United States. So clearly an impact of violence is the clogging of our emergency rooms with what our Centers for Disease Control are now calling intentional injury. Of course, contrasting with a more common term and notion of accidental injury. One of the impacts, of course, to our healthcare system is that there aren't a whole lot of supports for families in difficulty. Something has happened in this country over the past 10 or 15 years that is very worrisome, particularly to myself, having worked in this area for about 15 years. And that is essentially the dismantling of our mental health system as we knew it. At one time, we had a movement towards community mental health and making services available to a broad segment of the population. Over the past 10 or 15 years, economics and lobbying has driven the resources to be almost entirely spent on the chronically mentally ill who have been deinstitutionalized. And as a result, at least in the state of Washington, and I hear that it's true in many other states across the country, what was once known as a serious form of mental health problem, and that is danger to self or others, is no longer a priority for the public mental health system. And we are certainly paying the price for this deprioritization of these problems. So we are in the midst of trying to discover an alternative model for dealing with these sorts of problems. And we'll be talking about that alternative model as it comes into general health care. I really want to comment before leaving the notion of mental health that this is a situation in which the whole healthcare system is going to have to come to grips with whose problem this is. And one of the things that I had heard when I had personally advocated for the continued prioritization of violence, whether it be victimization or the perpetration of violence, as a serious mental health concern, was that people who have mental health problems really are no more violent than anyone else in the United States. In fact, the position was taken that they are less violent than people, the general population of the United States. I want to share with you just very briefly some data that would suggest that that simply is not the case. There has been a large-scale study published in 1990 consisting of a very representative sampling of 10,000 individuals with a variety of diagnoses, and looking at the incidence of violent behavior. And some of you may be familiar with some of those terms who have a mental health background or work in such settings. You'll see that the percent violent for having no disorder, and this is done by very structured, reliable diagnostic interviewing, and the sampling again is done in various cities across the United States to obtain a representative sample of the general population. You can see there's a variety of diagnoses that are associated with increased likelihood of violent behavior that goes far beyond the major mental disorders of affective disorder or schizophrenia. And you can see drug abuse and dependence and alcohol abuse being extraordinarily high in the rates of violence observed in those populations. Interesting enough, it shows that this finding not only holds for men, but for women as well. So this is not a gender-related finding, but it's across genders. Of course, the rates of violence are going to be higher for males than females. That's a fairly consistent finding across most forms of violence. Not all, but most forms. And there is an indication that when people are diagnosed with multiple diagnoses, the likelihood of violence increases proportionally. And those of you who work in settings in counseling or mental health settings will know that it's very common for more than one diagnosis to be applicable in a particular case. So we really need to look at what we have done critically in terms of public policy and how we've traded off one need against another. And in my experience, most of the citizens of the United States really are not aware that publicly, in terms of our healthcare systems, we have deprioritized danger to self and others as a problem. And I think most people would be shocked to learn that that, in fact, has been one of the economic trade-offs of the past 10 or 15 years. But it certainly has been. As you may have observed in the news clip that was shown there, part of this cost or impact is hidden, because what has happened is that a lot of what had been handled by the mental health system has now been transferred over to the criminal justice system. And it's curious to me, rather ironic to observe that in this very, very exciting time in which many things have happened, the Berlin Wall has come down, nuclear threat has decreased. We have now discovered that the biggest threat of violence and aggression does not lie without, but within. We have discovered the enemy, and it is us. The criminal justice system, if you will, in my opinion, has become the new military-industrial complex in this country. And particularly with men who have health problems and mental health problems, that by and large is the treatment that they get. And again, we need to ask ourselves, we need to challenge ourselves in the healthcare system and ask ourselves, is this the type of situation that we want? We're relying more on punitive, incarcerating measures, which are appropriate, but overuse of them results in a situation in which there are projections. And this I have from the Attorney General, from a discussion with the Secretary of the Department of Corrections in Washington State. Christine Gregoire is our Attorney General. She once gave a talk. She sat down with Chase Rivlin, our Secretary for the Department of Corrections. They looked at our trends towards using the criminal justice system to deal with social problems over the past 20 years. And they made an interesting projection. that if the current trend continues to build prison and jail space, that by the year 2050 in Washington State, every citizen will either be behind bars or tending to those who are behind bars. These are very esteemed public officials who do not make extreme comments or statements, but that's where we're heading. Question or comment?
How do you deal with the public perception that the reason we're having violence is you didn't do enough incarceration to begin with? If we had incarcerated earlier, thrown out all the prevention and mental health programs earlier, we would have been in a mess. So in fact, what we're doing is the public response is just what you're saying, build more prisons.
Well, I think there are reasonable arguments on either side of the coin there. Many people are preaching prevention and early intervention through our educational systems and through our healthcare systems. And some people are saying, well, what we need is more criminal justice response. I think we need to look critically at the research and acknowledge that what the criminal justice system does is contain violence and offer temporary protection in many cases to victims. The evidence regarding deterrence is very weak to non-existent. And although a lot of people would like to believe that whenever we lock someone up, we're sending a message to everyone who might think about engaging in that behavior, it really is not demonstrating that that happens. The individuals who engage in these behaviors rarely think about such things. We all think about them. Those of us who are nonviolent in the community. It has a tremendous impact on people who are not prone to be violent. But upon people who are prone to be violent, very little impact. The other argument is, and I do have an overhead here, and rather than look for it here, there's a saying that there's a real truth to this argument here, and I don't have it here, but I'll quote it. It's a rather vulgar kind of quote, but I think I can share it with you. This is a criticism that is offered. And it talks about the limitations of prevention or early intervention responses. And it goes something like this. When you're up to your ass in alligators, it's hard to remember that your original intent was to drain the swamp. And I think really we are in a situation, as far as violence is concerned, that we are clearly, if not up to our ass, up to our ears in alligators currently. And so we have a lot of work to do in this area that's going to require a variety of different types of intervention. My own position is that both positions are valid, but if you overuse or expect too much from one system, you're going to have disappointing results. And violence is the sort of thing that cuts across systems, and certainly is a major problem for the healthcare industry and system, and I'll present some data to suggest why that case can be made with some degree of power. I don't want to give you the impression that all the problems that we have are as a result of the dismantling of the mental health system. Clearly, we have a situation which suggests that something is going on in the swamp. And what I'd like to do is present a couple overheads for you, and I'm going to juxtapose two images for you. And I'd like you to hold the first one that I show you in your head, and then I'll put the second one up. Holding that image in your head, I would like to go to this one. Indeed, something has gone wrong with what I consider the ultimate infrastructure in this country, and that is the American family. And what you see here are kind of interesting portraits of different points in time. And although the Leave It to Beaver scenario of the family was somewhat unrealistic and idyllic in some ways, and perhaps not the sort of notion of modern gender roles that we would like to have today, the family did spend time with their kids. It was available to the kids to problem solve, to help them through difficult periods of time, and to offer pro-social modeling. What we have as a family today is something really quite different. It is a fragmented family that really has, because of socioeconomic press and the unending chase after the American dream, little time to spend with its children. And now it takes two parents to make the relative income that one used to make about 20, 25 years ago. And there's a price to pay. This, of course, being The Simpsons, or what I like to call the symptoms. A presentation in its own right could be about the dynamics and the origins of the increase in violence. There's a lot of roots to this problem, some of them socioeconomic, indeed, some of them cultural. This is an actual document that I found in a shop up in Snohomish County in Washington State. This was intended to be funny. It reflects certain attitudes that are still prevalent in parts of this country and with certain individuals. I've left the person's name who bestowed this document and received it, hoping that one day perhaps they would be in the audience when I presented this and be appropriately ashamed of themselves. I'm told also, although this is a document that originated, I think the copyright is about 1957, that in the past 5 years, a small wallet-sized version of this has been spotted in a vending machine in the New York subway. So clearly there are some cultural dynamics. Violence breeds upon a number of things related to sexism. There's a special issue we're doing in the journal on violence towards women of color, on racism. And general intolerance of each other and diversity. It's clear that when we make some individuals in our community less equal than others, they will be the ones to suffer first and the most. And the people who are suffering the first and the most appear to be, by tradition, those who supposedly go first and are protected in times of an emergency, that is, our women and children. So let's talk a bit more about the impact on the healthcare system. I presented, I know, some gloom and doom here for you. I don't want to present a gloom and doom or hopeless picture for you, because lucky for us, there is currently a call to arms in the community and within the healthcare system. Domestic violence intervention calls for more than treating injuries. The expanded model that people are considering now is the public health model, and that is violence can be viewed as an intentional injury, as an unhealthy set or cluster of behaviors, and can be addressed by the same methodologies that are being utilized to address other unhealthy behaviors, whether it be diet, whether it be accidental injuries of various types. Smoking. Part of the impact on the healthcare system is to change the way we go about treating injuries and looking at them and the way we deal with victims. Problems typically in the medical system have involved misdiagnosis or underdiagnosis of the problem. Treatment of physical symptoms only, bandaging up victims and sending them on their way, often returning them to the very environment which has caused the injury. Medicating symptoms, depression, anxiety, insomnia, or providing well-intended advice which helps maintain the risk for abuse and injury, and that is, well, why don't you take some time or take a vacation, it'll do you a lot of good, this sort of thing. And of course, blaming the victim for being somehow irresponsible or doing something that has set them up to become a victim or to be injured in some way. There have been a lot of studies of who gets victimized, and I can tell you that the major predictor, there are actually two. One is having been exposed to violence in family of origin, and the other one is being in close proximity to a perpetrator. Other than that, there is no personality difference. There is no masochistic. There is no preceding dependent profile. A lot of the dependency that you see is part of a syndrome that develops subsequent to the violence and does not precede it. I'd like to do another clip of a tape, show you some of the work that we're doing to train healthcare professionals and give you a sense of part of what this looks like as a protocol. And what you'll see is a potential victim coming into a doctor's office and the type of workup that we're recommending that they receive. That'll be the second tape.
Good morning, Ms. Adams.
Morning.
How are you today?
Well, about the same. I still have that cramp in my side, and I feel bloated.
Last time we had talked about some dietary changes. Have those been helpful at all?
Well, actually, I tried it for a couple of days, but I didn't notice any difference, so, well, actually, I hate bran.
Is there anything you've noticed that makes the pain particularly worse?
No, it seems to come and go. I have noticed it moving up my chest, right over my heart, and sometimes I feel like I'm having a heart attack.
That is concerning. When does that happen?
It varies, usually in the evening.
Does it happen with exercise at all?
No, actually, it feels better if I exercise, but I haven't been getting to the gym lately.
Why is that?
Well, we sold our second car, and my husband takes me back and forth from work.
That sounds somewhat difficult to me. Has that been burdensome to you to not have that second car?
Oh no, it's okay. Better for the environment. But actually, what's been bothering me is that I'm so tired lately. I just don't have any energy. I'm exhausted. Why, if I do the laundry, I'm exhausted.
Has sleep been disturbed? Is your sleep pattern normal?
Well, actually, I don't sleep too well. I just can't seem to shut my mind off.
Is there anything that you've been able to identify that's bothering you?
No, I'm just kind of a nervous person. I'm sure, though, if you gave me some medicine to help me sleep better, that I would be fine.
Well, has your appetite been disturbed?
Actually, no, I have a wonderful appetite.
And your mood?
Well, I'm sure my mood would be fine if I just had some more energy.
How are things at work?
Fine.
Any new particular stresses or responsibilities there?
No new stresses.
And how are things at home?
Fine.
Between you and your husband, things going all right?
Well, everything's fine now. In fact, he was so sweet. He just brought me a dozen roses the other day.
Things are fine now? Was there a problem previously?
Well, no. It's just that he's a bit of a perfectionist, and he just likes to have things go his way. And, well, he really is a wonderful guy. Why, all the neighbors, well, they all comment on that.
Ms. Adams, all couples argue. What happens when you and Mr. Adams disagree?
Well, the usual. We go back and forth until one of us gives in.
In some couples, one person may actually end up hitting or hurting the other during a disagreement. Has that ever happened to you?
No. Why on earth would you ask that?
Well, I ask all my patients who have symptoms that may be related to stress. Unfortunately, violence in the home is an important issue for many women, and it's something that I need to know about as a doctor, just because it affects people's health.
Well, do you have anything to make me feel better?
Well, I think we need to do a little bit more investigation about the cause of your pain. As you know, the x-rays and the ultrasound, the other tests that we did, they did not reveal anything abnormal. That's good news, but it doesn't give us an answer to the question of what's going on. That's what we need to find out.
Why don't you stop it there? Thank you. These are sort of patterns. I don't know. I'll read some of this. I know the print may be small for some of you to pick up from out there. Injuries that are not likely to be caused by an accident or follow the pattern of an accident. Woman minimizing the frequency and seriousness of the injuries. Woman presents for treatment on 1 or more days after the injury. Woman states she's accident prone. As in the case of child abuse, finding wounds or injuries in various stages of healing. A lot of presentations around somatic complaints of unclear origin, stress syndromes, anxiety problems. You know, the impact upon the healthcare system is not simply in terms of physical injury, but in fact, when you look at anxiety disorders and depression, the contribution of abuse, either in family of origin or in current family relationships, is a major contributor to that, is rarely discussed. I work in a medical setting, and boy, when people find a genetic component that would increase vulnerability and account for 10% of the variance, there is a big press release how we've discovered the genetic code relating to why some people get depressed and anxious. I can assure you that the contribution of abuse is huge in comparison to genetic inputs to those types of disorders. The unspoken, hidden, untalked about contributor to a variety of stress disorders and mental health problems is violence and abuse. And you can look at some of the statistics here. One study found up to 64% of hospitalized female psychiatric patients had histories of being physically abused as adults. A lot of presentations of primary care physicians. And again, we're talking about repeated visits, numerous diagnostic tests that often don't reveal a physiological source for the problem, a lot of expenditure of healthcare dollars. Tendency to prescribe drugs, become addicted to drugs. The contribution to alcoholism in women is great as well, where the alcohol abuse follows the physical and psychological abuse. Why don't we play another segment of the tape? Another visit with the same doctor by the same woman. She has her husband here today.
Mr. and Mrs. Adams, hello. What brings you in today?
Well, she fell down the steps a couple days ago. Her chest keeps hurting. We're afraid she may have broken something.
What caused you to fall?
She's always been a little clumsy. I call her Miss Two Left Feet.
Mrs. Adams, can you tell me what happened?
Well, I must have tripped up 5 or 6 stairs and hurt my left side and my right cheek.
Did you lose consciousness?
No, I was a bit shaken, but I didn't pass out.
Did you hurt your arms or your legs?
No, but when I fell, I must have grabbed the banister with my right hand because I twisted my wrist, but my legs and arms are fine.
Are you having any trouble breathing?
No, she's not.
Mrs. Adams?
No, but it is hard for me to breathe in deep, and I can't lay on my left side.
Could we get something like a chest x-ray, doctor? I'm really worried about my wife.
Well, I think you may be right. We may need a chest x-ray. I need to examine your wife. You may want to step out and have a cup of coffee. It's going to be a while, especially if we need to get this chest x-ray.
I don't want to leave her alone. And she feels much more comfortable with me here, don't you, honey?
Well, I understand how you feel. You're clearly concerned about your wife, but I need to examine her, and we need to have a nurse in here to help me with that. This room is too tight to have all those people in here. If you could just step outside, I'll come get you at the first possible moment.
No, okay. I'll be notified.
Mrs. Adams, what can you tell me about how you felt?
Well, I was carrying a laundry basket upstairs, and I must have tripped on the top stair.
Are there banisters on the stairs?
Yes, on the left side.
On the left side, so you fell on your left side.
Mm-hmm.
And you hurt your right wrist by grabbing the banister. Is that how it happened?
Oh, well, I may be a little confused about how I hurt my right hand.
I'm concerned when I see injuries like this that they may have been inflicted by someone. Is this what happened here?
No. I just, I don't know what I'm going to do. He's never hurt me this bad before.
This is not the first time your husband has hit you?
No, it's been on and off for the last 2 years.
Okay, why don't we stop?
But I know he doesn't mean to do it.
The tape goes on and discuss what is being recommended as the more comprehensive public health approach to dealing with intentional injury. With the major steps being of this type here. We have a series of tapes that we've developed for healthcare professionals because a lot of this is education and going from a different model of treatment to a more comprehensive interventive model. And so we have tapes of them intervening, of course, with this woman, and then also the physician meeting with her husband and what to do there. Also some tapes on elder abuse and other types of violence here. Now, the focus on family violence is incredibly important because I believe it is the breeding ground for violence of all forms in the community. And let me present a graph here that I think will demonstrate that. What you see here on the left side of the dotted vertical line are smoking, high blood pressure, exercise, cholesterol, weight, type A behaviors, risk factors as they contribute to heart disease. To the right of the dotted line, you have the risk factor of having been exposed as a child to violence in the home, and the multifold risk compared to someone not exposed. So as you can see, the risk factor is huge in comparison to what we call major risk for heart disease. A child will have violent behavior in childhood and discipline problems in school twofold if they are exposed during their, quote, latency years. As they become an adolescent, the chances of them getting involved with the police through delinquency is about 4 times to 5 times as great. And then as they become an adult, the risk of them becoming a violent person, either should they have a family themselves or if they don't have a family, generally in the community, is 8 to 10 times. And this is huge in proportion to smoking's contribution to heart disease alone, for example. So there's a lot of potential for early intervention and prevention through intervention with exposure to violence in the family. Another way of saying this is a quote from Edna St. Vincent Millay. It's one of my favorites. It is not true that life is one damn thing after another. It's the same damn thing over and over. And I think this is one of the more articulate representations of what we call the intergenerational contagion of violence. There are many risk factors for violent behavior in our youth. Be aware that during the past 5 years, if you think youth violence is increasing, be aware that nationwide, homicides, child to child, youth to youth, has increased 75% in this country. One of the great contributors is the availability of guns, which most children and youth get where? A, from their drug dealer, B, from a gun shop, 3, from home. From the home. That's the immediate emergency cost to repair a gunshot injury at Harborview Medical Center. The average cost for dealing with child abuse or spouse abuse is about $10,000 to $11,000. If we were to make guns less available, and people often say, for example, guns don't kill people, people do. They would only use some other method. If we gave all the people who use guns, knives, and allowed them to stab their victims, the data would indicate that at our hospital alone, we would save about $1.3 million a year. If you project this nationwide, again, assuming the same rates of violence, that violence would not decrease, only the method of attacking would be less lethal through less access to guns. The projected savings would be in excess of $500 million a year. Projected across settings such as where I work across the country. Again, some more work published in the journal Violence and Victims, which is in its 9th year. And again, this is another hopeful sign. We've got a journal which is being contributed to nationally and internationally, now in our 9th year of publication. A lot more interest in prevention and early intervention developing. And there are programs that involve hospitals, interfacing with communities. There are programs that involve hospitals and clinics, interfacing with the schools. So the recommendations that I make in terms of challenges and impacts upon the healthcare system are, as number one, we need to include violent behavior and its consequences, its perpetration and victimization as a healthcare priority. Where it has been lost as a mental health priority, it needs to be restored. We need to look beyond diagnosis. Violence is the problem. It is sometimes related to diagnoses, but it's a problem in its own right. It has a life, or if you will, a death of its own. We need to expand our existing advocacy models. Our system is fragmented. We've got people who care about children, people who care about women. We've got people who care about what goes on in the schools. We have people who care about expenditures in the criminal justice system. We got people who care about responsible use of guns. They all need to come together, get out of their little corner of advocacy, and come together and take a joint stand against violence to make this a priority in this country. Integrating public health and criminal justice interventions, a question that was asked. We need multiple systems at work. This is a very resistant and difficult problem that is not going to go away. Again, the forecast is for not only more of the same, but for an increase in violence over the years to come. Acknowledge all family members as worthy of all forms of intervention. We must not repeat the same bias and discrimination and sexism that helps originate the problem in our attempts to solve it. Increasing our knowledge about victims so that we can have an understanding and develop programs accordingly. The same with perpetrators. There are too many perpetrators in the community to consider them all as simply criminals that should be locked up and thrown away. And we're ravaging the diversity in our community. The violence is a very discriminatory type of public health problem that ravages our minorities in our society. Adopting minimum standards and protocols in the healthcare setting is critically important to offer a modicum of public protection. Again, viewing these things as public health problems and not as private problems. That's basically what I thought I had time to share with you today. I hope some of the information has been helpful in stimulating your own thinking about what you might do. I know many of you are students who are deciding career-wise what to do with your lives and where to make a commitment and where there may be opportunities. I can assure you that there are opportunities in social work, in nursing, in medicine, in psychology, in the law, in this area. This problem cuts across disciplines, and it is the job of all of those disciplines to come to grip with it and try to make some changes. So there's a lot still to be done in this area, and of course, this is not a pretty thing to look at. It is a difficult problem area, but we need the contribution of new professionals entering to make a commitment to this area to make progress. Any questions that you might have at this point? I understand there's going to be a panel a bit later in which questions could be asked.
Right. We have to get him off to lunch so that he will be available at 1 o'clock. There will be a panel at 1 o'clock this afternoon in the Bonner Room of the Student Union Building. That will last an hour and a half, and there will be an opportunity then to interact with the panel members and with Dr. Maiuro. So if you have any questions and are able to come, please come to 1 o'clock at the Bonner Room, and we'll be glad to talk with you then. Thank you very much for coming.